Good morning and welcome to ANAwareness Week 2021. We're so excited to have you with us today and throughout this week. I want to thank Mayo Clinic for this great slate of presentations covering a wide variety of topics relevant to the AN community. We have a lot to share with you this week, and we're grateful for all the time and the effort that's gone into putting this together. Today, we're going to start with Dr. Jeffrey Staab, who will discuss with us cognitive issues associated with Acoustic Neuroma in a presentation called Resilience and Distress. And really, it's just going to kind of be a discussion. So if you have questions, go ahead and start sending those in. Dr. Staab, I'm going to let you introduce yourself in just a minute, but I want to let people know a few things about how this works before we get going. So first of all, everybody who's attending is in listen-only mode. If you have questions throughout the presentation, you can ask them in the questions box that's in your toolbar. If you're on Facebook and you're listening that way, you can just write your questions in the comment section. We'll be monitoring that as well. There should be captions at the bottom of your screen. If you don't see them, you can click the captions button that's in your toolbar to activate them. If you're watching on Facebook, again, they should just be active. We are recording this presentation, and it will be housed on the ANAwareness Week landing page in the presentation section. So we'll be updating that throughout the day today and then throughout the week as we get through these presentations. We'll also keep it on our Facebook page, and we will add it to the video library on our website. There are tons of ways to get involved in Awareness Week this week. If you visit our website at www.anausa.org, there's a slider on the homepage that will link you to the landing page, which has our schedule of presentations. It has bios and photos of all our doctors who are going to be speaking and presenting. There's also other ways to get involved. So it should have everything that you need to know. Okay, Dr. Staab, welcome. Thank you for being here today. And please tell us a little bit about your work with acoustic neuroma patients and their families.
Well, thanks, Melissa. I appreciate you having us. Not just me, but the rest of our team here at Mayo Clinic to be part of this Awareness Week. I am a psychiatrist. I'm professor and chair of the Department of Psychiatry and Psychology here at Mayo Clinic in Rochester, Minnesota. My area of professional interest has been in patients with dizziness and balance disorders for more than a couple of decades now. So first at the University of Pennsylvania, now here at Mayo, I've been fortunate to work with colleagues in ENT and neurology on patients with a variety of different vestibular illnesses over the years. So that, of course, includes patients with AN.
Great. Well, thank you again for being here. We're going to go ahead and get right into some questions. We get questions from patients all the time dealing with cognitive issues that may or may not be associated with their acoustic neuroma, but they feel strongly that they are, and that the result is because of either their treatment or the tumor itself. There's a lot of questions about it and things that are just unknown. So we do get a lot of these questions. Right away, one of our board members had a question about after acoustic neuroma surgery, how can they deal with the cognitive issues where they're in the middle of a sentence? We do hear this a lot where people sort of have brain fog and they'll be in the middle of a sentence and they just can't remember a word. And it kind of leads to confidence issues about going out and being social and that sort of thing. So would you suggest that patients deal with that kind of thing?
So first, I think, is to know what we know, and there is some information that we do know about why that happens. Mm-hmm. We don't. This is a tough problem. We don't have it all figured out, but there's a couple of pieces of research data that are worth knowing about, because one of the first challenge in dealing with any problem is to be able to understand it as best we can. It's harder to deal with a problem that's just sort of, we don't know why it is, versus one we have at least a little bit of an inkling about. So research coming from a variety of different sources, but including brain imaging studies that look at the activity of and functioning of parts of the brain that have to deal with cognition, so attention, memory, spatial orientation, show that the vestibular system has a pretty strong input to those areas, in particular an area of the brain called the hippocampus.
Mhm.
Now, the hippocampus does two important things. It has multiple tasks, but in this particular case, it does two important things. One is that it is an integral part of working memory, and working memory is that that short-term memory where you just sort of bring in facts, both information you know, but also other facts that you have to deal with to solve a specific problem. So in the days when we actually had to look up phone numbers in the phone book, where you would look up the phone number, you'd remember the 7 digits to do the task of dialing, but then you wouldn't remember it after you were done unless it was a phone number you were going to use again and again.
Right.
So that's the working memory. Bits of information come together, you use it to do a task, and then those bits of information are not necessarily things that you're going to remember over the long run. So that kind of memory. And then the other is spatial orientation or spatial memory. That is, where am I right now? What's going on around me? And what's the map? We draw a map in our head of space, and the hippocampus is involved in that. So it turns out that people who have bilateral vestibular problems have a noticeable change in the structure and function of the hippocampus, smaller and less active. Even people with unilateral problems do a little bit as well. And most recently, we've been working with people with different types of chronic dizziness that shows that also the hippocampus is affected in its connections with the rest of the brain. Now, we know that is there. We don't know why it happens, but we do know it's there. And so our thoughts are that we as humans, because we're mobile, our working memory and our spatial memory oftentimes are both necessary to do a task. And so there may well be a bit of a neurological basis of even a peripheral vestibular problem like a neuroma affecting a central function.
Mhm.
The additional piece is if the tumor or its treatment has affected hearing, even if it's on one side, then we also sort of lose the ability to localize sounds in an environment, especially in a noisy environment.
Mhm.
And that means if you're trying to do something like track conversations or track activities that have any kind of a sound quality to them, just a split second behind in localizing where that's coming from. And with conversations, it means that you finally find out who's talking after they've said the first 3 words of their sentence.
Mhm.
So there are a couple of things that are neurologically based, trying to kind of compensate for those things. And so so in addition to knowing that happens, one practical thing is in situations where there are people that you know and people that you're confident that you can let them know that you do have a tumor that affects that affects sometimes hearing and attention, then you can have them potentially slow down a little bit
Mhm.
or wait so that you're able to look at them before they start to talk. These kind of little things where you can help to manipulate the environment a little bit better. Another practical point is when you can't do that, when you have no control over the situation that you're in, is to give yourself little breaks.
Mhm.
So if you're in a cognitively demanding environment and you realize you're starting to struggle a little bit, take a break
Yeah.
and do something a little bit differently, kind of a reset, if you will. And it doesn't mean that you have to stop doing something entirely. Sometimes when I talk to employers and employers are asking, well, what accommodations does this employee need because they have an AN? And we talk about breaks. Sometimes the employers say, oh, so you mean they need like extra breaks, like going off to a break room to get extra breaks? And that's
Mhm.
not what we're talking about. We're talking about breaking tasks up so that
Gotcha.
you're not doing something that's highly demanding cognitively, but you can break it up with something that's maybe a little bit less, and
Okay.
then come back. So those are some. So awareness that yes, there's a something that we're just starting to understand having to do with vestibular inputs to working memory spatial orientation systems. That those two work together, and so there's just a little bit of a information flow through the brain that's not going as well and as smoothly as before. That the hearing is an issue, and hearing and cognition and tracking is a problem, and then giving yourself short breaks in the midst of cognitively demanding tasks. And I think knowing those pieces, can help to make it a little bit less frustrating to have to deal with this when it comes up.
So that leads me into talking about fatigue, because we hear from a lot of patients that they are fatigued from trying to hear, from trying to balance, from trying to, just get through their day where they didn't experience that before. But we're trying to remember words. Just all of these things are just adding to what is necessary for their brains to do, and it tires them out. And some patients have said that, they're not sure if that has anything to do with their acoustic neuroma, but I think probably based on what you just said, it does.
Yes, and we hear that too. And we also hear it from patients who have other causes of chronic dizziness as well. And that is, if you think about, I have a good friend in Luxembourg who's a neurologist that I've worked with for a while, and he says something that I think is a neat little way to remember this, and that is that he says is the only time we know that we have a balanced system is when it's goofed up. Because otherwise it's just doing its thing in the background. Right. We don't pay any attention to the fact that we can stand up, bend over, turn around, roll over, jump, run down the hall, all of those kinds of things, drive a car 70 miles an hour down the road, because our spatial orientation system just takes care of all of that. Mm-hmm. But once there is a problem with it, then it is not as efficient. And it's so it not only does it have to work a little bit harder, but the second thing that it does is it calls our attention to the fact that it isn't working quite normally. And it's supposed to do that. I mean, if we stumble and fall, we're supposed to stop, chatting with somebody and pay attention to what we just tripped over, right, so that we don't end up, flat on our face, for example. So our body's vigilance system, threat alarm system, if you will, is supposed to make us pay attention to something that's malfunctioning in some way. And that's fine when we've just slipped, or when, something, something more acute, like we just kind of caught our thumb in the door or something along those lines, where there's an acute thing we have to respond to. But it takes a toll day in and day out if it's something that's constantly there. Mm-hmm. And so I think that you're right, Melissa, when you said it just feels like there's more to do. Mm-hmm. It feels like not only are you overtly aware of balance, or overtly aware of having to take extra steps to hear something, it's almost like throughout the entire day doing two tasks at once. So dual tasks all the time, keeping multiple balls in the air. And there, and so that is a legitimate way to think about this. It's not just somehow or another, that people aren't just up to it anymore, but that there is a way to think about this is there's just this little balance, little hearing tax that comes right off the top at the beginning of the day, and you only get what's left. Yeah. But saying that, I don't want to get people to think that, oh, well, I just have to be resigned to it. So sort of throw in the towel, because there's a difference between saying that is what it is. It's something that I have to deal with, that other people with AN have to deal with, but not everybody has to deal with. Mm-hmm. Okay, so it is. And then be able to take your physical strength, emotional strength, concentration, and so forth, and apply it to other things. Because if the mindset just becomes oh, this is just a burden that I have to bear, and I just have to, that kind of a thing, that just adds that sort of has a tendency psychologically to magnify the burden a little bit. So what I'm not saying is just say, oh, it's no big deal. What I am saying is sort of call it what it is, find a way to say it is what it is, and to say, but that's all it is, as opposed to it being, kind of feeling like it's just all encompassing, affects absolutely everything, every moment. And so sort of striking that perspective, yeah, is a bit of a challenge, but the good news is most people can do it, but kind of to acknowledge that it's not normal, and it's not going to be normal, but it's also going to be a bit of abnormal in a broader life. Right.
And you may need help. You might need help, in certain, like you mentioned, having someone sort of help you get through conversations, or help you figure out the right spot to sit, or somebody that you trust. I know that we often tell patients that. We've had a couple questions about these cognitive issues, and we've heard many people call acoustic neuroma an invisible illness. So unless you have facial issues associated with your tumor, it can be very invisible both before and after, difficult to diagnose, and then the issues that are chronic after. People are wondering though, how do you know if this is, or can you tell if this is because of the acoustic neuroma, or is this just because of aging or personality or something like that?
Right, right. That's a good question. A couple of people asked that. I can see that in the Q&A
Yeah.
thing. So the answer to that is that the first step is to talk to people who know you well. And if what they're saying is, yeah, we know that occasionally you have to catch up in the conversation and you miss words. But once you're engaged, once you know what we're talking about, once you're with us, you're as sharp as you've ever been. Mm-hmm. Then you know that you're dealing with some of these kind of AN things. Or if they say, we know you get tired a little bit easier, and at the end of the day, you're not quite as sharp, but when you're more rested, yeah, you're spot on, as good as I've ever seen you. Mm-hmm. Then you could be satisfied that probably you're dealing with some of these AN related factors that we're talking about. But if people start to say, or you start to notice, that you're missing little things, where did you put your keys, your glasses, that you get to places in familiar areas and momentarily kind of get disoriented or lost, even if just for a few seconds, kind of have to pause and reorient yourself, then there may be more problems related to memory illnesses, not directly to the acoustic neuroma. So it's a separation between sort of more global things that people are saying, or yes, we've noticed that you're a bit more forgetful, and in that case, thinking about there being another problem. But if it really is related to, catching up on conversations, being able to take a break, being able to do cognitively detailed tasks when you're rested and able to do them, and all those things are still your own sense, mm-hmm. and the sense of people who know you well is still that you're doing okay, then I don't think that you have to worry about other more significant memory disorders.
Sure. Okay. And we did have another question in the chat just about treatment. We have a couple different ones I'll ask. There's one about radiation. I'll ask that in a second, but can people experience cognitive issues even before they have treatment?
Yes, probably for the reasons we just talked about. So the things that we're talking about are not related to treatment effects only, mm-hmm. but can be related to just the presence of the tumor causing subtle changes in hearing and balance function. Even if they're subtle, they're still there. Mm-hmm. So the question about what about, is that magnified by treatment, I think is a bit complicated, because treatments have changed over the years, and things like both surgical interventions and radiation interventions have become more precise. And so we do know that, for example, that people who have brain cancers or metastatic cancers to the brain and need to get radiation to their whole brain in order to treat those kinds of cancers do have cognitive deficits that come from that kind of treatment. And as our radiation colleagues have gotten more and more precise with treating acoustic neuromas, they've been able to protect the large areas of the brain that that may be around the tumor. But there still may be, we don't know for sure, there still may be a little bit of of effect that does branch out a little bit beyond where the tumor might be. On the surgical side, even if the surgeons do a fabulous job, you still are going through a process that does, depending on where the tumor is, does mm-hmm. result in the brain having to be moved or stretched a little bit. And even if beautifully done from a surgical standpoint, some people after craniotomies, after surgery, do have the kinds of symptoms that we can see in some people after concussion. Now, I don't want to equate those two. Let's be really clear that we are talking about two different things. But but for some people, there does seem to be a little bit of an overlap in symptoms, and those symptoms being some some dizziness, kind of more of the sort of a vaguer, non-specific dizziness than spinning vertigo, trouble with fatigue, trouble with insomnia, trouble with attention, concentration, and memory, and sometimes a little bit of moodiness, although not so much the latter when it comes to surgery. And those things can take a while to recover. Those are ones that may take a few weeks, even a couple or more months to settle out. And they're subtle, and so they're really going to come up when you're in more demanding situations.
Okay. We have a couple questions about being out, in public, driving potentially, and really loud noises like sirens, and being very fearful of just driving and being out because of those loud noises, not being able to tell where they come from, and then not, it being really loud, and in some cases just painful for patients. How do you counsel patients who are dealing with feeling alone, feeling like they are sort of pulling back from their friend groups and things like that, because they're fearful of, anything? It could be loud noises, it could be not being able to keep up with conversation, it could be balance issues, and feeling like they might, fall or get dizzy all of a sudden. And so they sort of just pull back from what's going on, because they're afraid of that kind of thing.
So there's that, and there's one other fear that people have, and that is of looking foolish, or being embarrassed, saying the wrong thing, just looking like, they just can't keep up anymore. So it's the fears of, sort of physical harm, crashing a car or falling, maybe hurting somebody else, but it's also the social fears too. Those are two that cause people to pull back. So those are, I think that gets back to the question of sort of making necessary adaptations, and finding a way to make necessary adaptations that have minimal disruption, but still needed, versus ones that take on a life of their own.
Sure.
And they start to, oh well, I can't do that now. Oh, maybe I shouldn't. Maybe I'll just let that go by. Little things like somebody invites you to dinner and you say, oh no, why don't you go? I'll be okay. And that takes on a life of its own. And so rather than the adaptations being the sort of necessary ones that you have to put in perspective, there's this added layer of, the world getting smaller because you're less and less involved with it. So if that happens, and you notice that that's happening, again, as Melissa talked about earlier, being willing to reach out to other people, being willing to, instead of saying, no, I won't go, say, well, I'll go with you, but if it's too loud, we might have to leave early, or I might have to leave a little bit early. Or if it's too long, sometimes I get, kind of wears me out a little bit more. So, I might have to, maybe we'll drive separately. So if I need to leave early, I can go home. So there's a difference between being engaged and making accommodations. And again, for people and trust, kind of saying up front, might have to modify this a little bit versus just giving it up entirely.
Right.
If you really find that you're just stuck and you recognize, and other people are saying to you, you're just not involved anymore, then the psychologist can help with that. It's people with other illnesses have that same kind of a problem too. It's not unique to AN, and so psychologists do have an understanding of how these kind of necessary adaptations to having an illness can sort of spin out of control and be a little bit too much. And then they have specific ways, psychotherapy ways, behavioral ways, to kind of rein that avoidance back in and help you to re-engage.
Okay. There's a patient here who you may have spoken to, who talked about, said that you mentioned to them that they should talk to their brain, and this person uses that when walking on uneven ground, or even when they started driving. So they were just wondering if you could, give your viewpoint on that and maybe communicate that little bit of advice to everyone.
Yeah. So I think that this person will have to correct me if I'm wrong about that conversation, but I think that it was in the following sort of idea, and that is that you kind of have to tell your brain what it's supposed to be doing and what it's not supposed to be doing. In other words, our brain is supposed to kind of monitor the movements that we make, so it can plan the next step or the next turn when driving the car, those kind of things. But it's not supposed to be trumping everything else that you're doing. Nor is it supposed to be overly controlling those kinds of actions about space, orientation, hearing, so forth. So the idea is to sort of kind of check in and pay attention to the times in which your brain is trying to do too much, trying to overly control things, trying to because then you're kind of standing in your own way. So because hearing and balance are automatic, we have to sort of sometimes you have to sort of remind your brain that that's the way it's supposed to be, and that you don't have to consciously know about every step that you take and every move that you make, like the Police song from years ago goes. That's right. Yeah, that was about stalking, but it applies sort of what the threat system is doing, kind of paying attention to everything. So again, sometimes the talking to yourself part is about just sort of resetting the expectations of what different parts of the brain are supposed to be doing. Yes, the threat system is supposed to be watching every move that you make and every step that you take, but it isn't supposed to be telling you about it all the time, so that's what you're paying attention to, when what you really want to be doing is listening to your favorite song while you're driving to the store. Yeah. And so that's sort of this self-talk. And another one, sort of in the first thing in the morning, kind of get the day started, is to say to yourself, what am I doing today? Not how do I feel today? Because if you start with how do I feel today, then that mindset quickly starts crossing things off the list that you can't do. Or if you start to what do I want to do to, or what's on my schedule to do today, if you don't feel particularly good, then what you can say is, well, maybe I've got to adapt a little bit, but you can still stay engaged in the valued tasks, the people that you want to be with, the things that you want to do, as opposed to starting the day saying, oh, this could be a bad day because I don't feel very good, so I got to start scratching things. Right. And I think those are sort of the two self-talk things, or talking to your own brain kinds of things. Okay.
And what is, we had a patient ask about biofeedback. So what is that? And is that helpful, that therapy helpful with cognitive issues related to both either pre or post-treatment acoustic?
Right. So biofeedback comes in a lot of different forms, and essentially all of them, whether they're called biofeedback, neurofeedback, mindfulness, relaxation, all of these kind of things, what they're all getting at in one way or another is a way of relaxing, a way of just sort of relaxing your body and your brain, and also your emotions. And so it can be done in a whole variety of different ways. But the advantage of that is to sort of take the tension level down, whether it's sort of physical tension of, the strain that comes from kind of, moving about when, your balance may not be as sharp as it used to be, or just the mental strain that can come from the kinds of things that we've been talking about. What those kind of strategies do is they teach you to be able to kind of quickly take a break, and during that break time, just bring the tension and stress level down. And so whether it's done by sort of paced breathing, or whether it's done by learning to, just to through a biofeedback system. So what that does is if you're using formal biofeedback, then normally what will happen is you'll be hooked up to some sort of a monitor that's measuring some physical system. So measuring your heart rate, measuring your breathing, measuring sweating on your palm, which has to do with a level of arousal that you have, so threat sense or anxiety sense that you have. Some of the systems actually use the EEG, that what is called neurofeedback. They'll actually show you brain waves or pictures of the activity of the brain. But all of them are about training you to get to be in a mindset where you can slow those things down or settle them down a little bit. And then once you're able to do that on your own, you can do it without being hooked up to the devices that give you the pictures back. And therefore, wherever you are, whatever you're doing, you can take a moment and just settle the tension, settle the anxiety, settle the stress. And so in that way, biofeedback or any of these related techniques can be helpful.
Sure.
And they also can be used for treating anxiety disorders. So or depression. So if things get to the point where, you've gotten to the level of an anxiety or a depressive disorder, that can be part of a treatment plan too.
Okay. That's great. We had a question about talking to friends and family and trying to let them know what is going on with you and make them understand, again, because it's potentially invisible, or we hear from patients that they're like, well, you had the tumor out.
Mm-hmm.
Why is this still an issue? How should patients talk to their friends and family to let them know what is going on?
So I think the first thing to think about is, how close is this person and how much do they really need to know? Because there's sort of different levels of friends and family.
Yes.
Right. There's the neighbor a few houses down that you see from time to time and kind of wave hi to. And then there is, people that you live with day in and day out. So I think that's the first assessment. The amount of information that you'd give to different people is not the same. And it's information that you need to be comfortable with giving, and potentially then having them share with others that they might think should know. So that first level. And then second is is what do you want to get back from them from sharing the information? In other words, do you want their emotional support? In which case you may be talking, and what you may be sharing more about is how you do feel, the frustrations that you have, the sadness that you have, the anxiety, that some of these anxiety things that Melissa and I were just talking about. You may share the emotional feelings that you have, the emotional state that you have, because that's the kind of support that you want. Others, you may just want to look at you when they're talking to you. And so what you really want from them is a task.
Right.
And so you don't necessarily have to kind of spill everything about the emotional aspects of things. You may just focus on the kind of tasks that you need them to be a little bit more mindful of when they're interacting with you. So I think that's the biggest thing, is the first thing is what is it? Who is it that you're sharing with, and how close are they? How much do they need to know? And then what do you want them to understand that you need from them? And then that's the way to think about these kind of conversations. And also then give them a chance to ask what they need to know about you. Because sometimes people make assumptions, like you said. Well, your body looks fine to me, your face looks fine to me, you got treatment. And so they may be making presumptions, and they may have questions that they've not necessarily been willing to ask also.
Sure. Okay. This is a great question, and we at the ANA, we constantly are sort of battling this. We want to share information. We want to give people validation for everything that they're dealing with, and we want to, and everyone's so different, but we don't want to scare people. So there's a question really about. I had this patient had a large tumor removed and hasn't experienced any sort of cognitive issues, and she's wondering, do I need to worry about that? Is it coming? Is that something that's, going to happen? Or are there patients that just don't deal with this issue?
Yeah. So that's a great question. And I think that it applies to all of the things that we've talked about. So, cognitive issues, anxiety issues, depression issues, family issues, all of these kinds of things. All of these can happen in people with AN, but none of them happen to everybody. And there are lots of people that don't have any of them. So the most common outcome from a behavioral, cognitive, emotional standpoint is normal citizen with AN. And I think that's not to downplay the troubles that can happen with this, the things that we've talked about, but it's also kind of perspective. If we were really to look at outcomes, the majority of people are fortunate not to have to struggle with these kind of things, or if they do, temporarily. So you're right, it is an absolute balance for both individuals with AN, with the community of people with AN, and organizations like the ANA that are trying to be helpful, is to strike a balance between letting people know that these things can happen, an individual knowing, yes, I've had one or two of these kind of things, but not walking around like feeling like just the shoe's going to drop in just a moment.
Right.
And that's not always an easy balance, either for individuals or organizations, but keeping in mind that the most common outcome is that people won't have these things, maybe struggle a little bit, maybe sort of find a good perspective, and that the people who really, the burden is higher for any reason, are a smaller number, need our support and understanding, but it's not a universal experience.
Mhm. Exactly. Okay, that was a great answer. Thank you. What about re-engaging at work? We have a lot of patients who, some patients are able to go right back to work. Other patients have to completely change, what they were doing. They're just not able to go back. They go into something different. Or, some people are able to move back in gradually. And there doesn't be any kind of, we get the question all the time, like, how long will I be out after surgery? How long will I be out after radiation? And there's not, there's not a specific time. So how do you counsel people and help people as they're trying to re-engage at work and get back to their professional lives?
Right. So, I think the first thing is that it depends. Part of it depends on the kind of work that you do, but not sort of in a way that many people think about. So, for example, if we say, well, you could have some vertigo after you have surgery, and you happen to be a roofer, then your boss is going to say, don't come back until you're not dizzy. You can't go up on the roof.
Right.
And that seems like really straightforward. Okay, we get that. Everybody gets that. But it's also true that even somebody who is a construction worker like my father was, and these kinds of things, that there still are the cognitive tasks too. And somebody who may have an office job, who sits at a desk and goes to various meetings and is not doing something that is physically that demanding, still can have some of these cognitive difficulties or spatial difficulties. Sitting like we are in front of a computer screen, you still have to have decent spatial orientation to be able to do this kind of a task. So I think that the important conversation, hopefully you do have either a supervisor or an HR department that you can have some conversations with about this. And before treatment, let them know, and then have conversations about what symptoms you may have that are lingering and what accommodations that you may have to make, because it is individualized. It's individualized in two ways: what you need and what your company, what your company's procedures are for making those adjustments. And so, when we work with patients around this, we sort of set some general overall guidelines, but then let them and let their employers know that we may have to fine tune it for individual patients, and that we sometimes will have to do a little bit of education for employers around what it means to have a break. Doesn't mean 15 minutes of doing nothing. And about some of these cognitive things. If your employer allows a gradual return to work, then you can test out some of these things. And you and your employer can know how far you can go. Some employers say it's an all or none, that you have to be ready to come back fully, or they can't take you back part-time for whatever reason having to do with the company's tasks and policies and so forth. So I think in a nutshell is the discussion up front before treatment, so that there's no surprises that there may be some problems. And then as you get ready to return and as you start returning, keep the communication open as much as you can, hopefully with a boss that or HR system that you can have at least a decent relationship with.
Right.
And then working with your doctors to help to support that. One other important thing that sometimes patients misunderstand is that it's we as physicians that tell the employers what they need to be doing. That's actually not the way that the system works. The employer has the responsibility under the Americans with Disabilities Act to make the accommodations, and similar laws in other countries. Again, there's differences across the globe, but the employer has that responsibility, and you working with your employer have the responsibility to let them know what your needs are and to see what accommodations can be made. As physicians, we do two things. One is we say what deficits there are that have to be accommodated and what kind of accommodations might medically be useful, but we can't force or demand that there's nothing anywhere in the legal statutes that allow us to do that. So we inform, endorse, and potentially certify the need for these kind of things, but the making of them and the setting of them in place really is on the employer side.
Okay. We talked a little bit about dealing with hearing loss and dealing with balance issues, and that those, contribute to fatigue. And there's been questions about whether or not that contributes to or exacerbates these cognitive issues, which we've kind of already touched on. But if a patient goes and gets vestibular therapy, or they get a hearing aid, or they do something that will potentially help them manage some of these sideline problems, can those then in turn help or even make better some of the cognitive issues that they might be dealing with?
Yeah, we have seen that happen, and not infrequently. So so that better control of the hearing and balance deficits and better compensation for those, either by assistive devices like hearing aid, or by physical and rehabilitation therapy, does improve the cognitive deficits. And that's actually how we ask patients to approach it, because we haven't been particularly successful in saying, well, we'll give you some, there's a variety of different, both prescription and over-the-counter medicines that are used for, memory problems and concentration problems. And we haven't been particularly successful in going that route, whether somebody is buying, over-the-counter, supplements, or when we've tried a few different medications that sometimes will do this. So I think, Melissa, what you said, the approach of attending to the hearing, finding the best strategy to counter the deficit, and attending to the balance deficits really is the way that we've had more success in diminishing the cognitive side effects.
Okay. And when you have patients who deal with a more severe, almost depression, and that kind of thing, where they, are really mourning the loss of the life that they had, or if they have facial issues and they are really struggling with that, or they have, debilitating vertigo that just, keeps them from being able to go out. Is that associated with acoustic neuroma ever? And I'm asking that so that, because we do have patients who ask us that question. And how do you deal with that?
So the answer is yes. There are patients who get to the point where we would say you do have a psychiatric illness or psychiatric disorder now. Your depression is not just a little struggle with kind of coming to terms with it, but it's taken on the way to think about that again is that it's taken on a life of its own. So that day in and day out, mood is low, day in and day out, anxious and restless, not sleeping, not eating because of those kind of things, not engaging, withdrawn. So yes, it can get to that level. And there are two ways that it can. One is that there are people who may have had that already and then got an acoustic neuroma later in life, or it was discovered later in life. And then second is that the burden of the illness can get to the point where, for some people, they develop later depression or anxiety disorders. Either way, whichever route it is, the treatments that we have available, both medications and psychotherapy, can be helpful. Sometimes depression will say to people, well, how can you ever get not depressed if you have the acoustic neuroma? They're not going to take it away. How is depression going to go away? That actually doesn't follow. We really can treat the depression. And it doesn't mean that you kind of forget about and imagine that you don't have an acoustic neuroma or any of the complications that may have come from it. But rather, in treating depression and treating anxiety, people can get to the point where those added burdens are lifted and have better perspective on the symptoms that are related to the consequences of the neuroma. So when that occurs, we really say to people, you've got two things, and we have to have a treatment plan that accomplishes the treatment for two things, not just say you're stuck, you're doomed to have this happen because you have a neuroma, and just, sorry. We
Mhm.
really can treat the psychological burden that comes with it if it reaches the level of an illness.
Okay. And in patients that you've seen, has there been a big difference between long-term and short-term issues? What kind of improvement, I guess, do you see where you see a short-term issue that is, maybe severe at the beginning, and then there might be improvement? We had someone that asked about brain fog and does it ever go away? And she says that there's been improvement since her treatment 3 years ago, but it's still there. So, and then we had somebody else ask about long-term issues associated with radiation. So, um, do you see a big difference between the short-term sort of emergent issues kind of right after diagnosis or treatment, and then things that go on for years and years following?
Yeah, so there's a couple of things. There's a lot of things some of that you mentioned that can be short term,
Mhm.
and there it is just a matter of staying with the recovery plan, and letting it and not giving up too quickly on how far and how fast your recovery will be, because that does vary from person to person. Now, once you get out to months, many months,
Mhm.
then it is a little bit more. We have to do a little bit more of, okay, there's an element of this that it is what it is, and now making sort of adaptations, and coming to terms with it, and making sure that um, you that people are using the kind of adaptation strategies that really can keep them healthy, both physically and psychologically. And those do exist, and there are ways to enhance those processes. And from the treatment standpoint, again, psychological treatment standpoint for those, the the ways that we approach that are things that we've learned from our colleagues that have been studying chronic pain
Mhm.
for half a century. And what they've found in helping people to live the best quality of lives that they can when they have different chronic pain conditions is to help them to focus on the life that they're living as opposed to the pain. So what I mentioned earlier, that you get up in the day and what am I doing today, as opposed to how do I feel today? That comes from the sort of strategies that have been used in the pain world. So if you find that you're really struggling with some of these persistent physical symptoms, whichever they may be, um, looking to take advantage of some of the information that we've learned in helping people with chronic pain and other debilitating physical conditions can be helpful.
Mhm.
Um, Not all psychiatrists, psychologists will know about that, but ones who are familiar with and work with patients with medical conditions would be ones that would be a little bit more likely. Ones who work in rehabilitation settings, ones who work with in pain programs, would be ones who would understand this a little bit more and could help with that. So um, the when these kind of symptoms have settled in, as again, if you look, the recovery is not linear. The recovery is a lot at the beginning and then gradual residual that sort of can linger for a long time. So if you're really out on that lingering tail and feeling like you need some help with that, then there are these strategies within psychiatry and psychology, but not just sort of general, oh, it's anxiety and depression. That's
Mhm.
not, if it's there, fine, that needs to be treated. But I think what this question really gets at is that healthy adaptation
Right.
to lingering symptoms. And there are very specific treatment strategies for that, not medications, treatment strategies so much, but lifestyle, some of these things like you were talking about with biofeedback and
Mhm.
meditation before, and certain tools that have been developed for patients who are dealing with other chronic nagging physical conditions that are not life-threatening but life-altering, and how
Sure.
do you make the alteration as little as possible. Those kind of strategies are around, and it takes a little bit of effort, but finding them specifically with people who psychologists, psychiatrists who are dealing with patients with medical conditions as opposed to patients with, bipolar disorder, schizophrenia. Our,
Mhm.
our fields have these subspecialties, and you want to, look in those directions.
Okay.
Okay.
Do you see a huge difference in the symptoms and experiences, I guess, and chronic issues that come up cognitively in patients that have small tumors versus large tumors, particularly with acoustic neuroma?
Yeah, I don't know. I'll say to you that I don't know that how well that has been. I don't know that we have data that can give us the kind of really hard factual responses that you want from that,
Mm-hmm.
because it hasn't been studied nearly to the same extent as more tumor related outcomes have been, where there's a lot of data about size and tumor and what it means. And I think part of the situation is that there is some more individual variability in the kind of outcomes that we've been talking about that wouldn't be related directly to how big or how small the tumor is or which type of treatment. So I think that it is a little bit more individualized than the kind of systematic approaches that our surgical and radiation colleagues can go by, because they've
Mm-hmm.
done a nice job of collecting the information that they need. We're a little lagging behind them in that regard.
Well, that's a great answer, honestly, because it's difficult to kind of figure that out. I want to let people know that we're getting questions on Facebook. That's why I keep looking over here, and then also on the Zoom call or on the webinar, and things that are specific to hearing or balance or those kinds of things. We are tracking those. I am going to hold on to those probably and ask those in the webinars that are geared toward that topic. So I'm not just ignoring you. I hope
I appreciate that, Melissa.
That.
We want to sort of stay in our lane here,
Exactly.
and make and make your viewers and your listeners have the opportunity to talk to the people that are most expert
Exactly.
with the kind of questions that they're
Exactly.
raising. Yeah, I agree with you about that. Yes.
Okay, great. Well, I just wanted to let everyone know that we are coming to the end of our time. We had a question about personality change.
Yes, I saw that one.
You saw that one?
Yeah.
So can you comment on that a little bit?
Sure, that's a tough one. Fortunately, it's not a common one.
Yeah.
But so there are several kinds of brain illnesses, MS, strokes, Parkinson's disease to some extent, brain injury, so concussions, that can produce the kind of personality changes that the writer mentioned. And specifically, this writer said that the writer's partner sort of had originally been a little bit more reserved, now is a bit more outgoing, kind of seems like their emotional equilibrium got off. So these different illnesses and what we believe happens is that the expression of emotions is kind of a multi-layered thing in the brain.
Mm-hmm.
There's sort of the basic parts of the brain that trigger our instinctive emotions: fear, anger, kind of joy, that sort of basic emotions. And then on top of that are a couple of layers. One that incorporates those emotions into the context so that we don't, laugh in the wrong place, so to speak,
Sure.
even if and then second, another layer that kind of smooths them out and allows us to express them as we would in our particular group or culture.
Mm-hmm.
So it's a multi-layered process. And what we think happens when these changes occur is that the connections among those systems that bring those layers together get disrupted, so that they're not as efficient. And therefore, emotions can come through a bit unfiltered.
Mm-hmm.
Thoughts, people say, well, they just say whatever they're thinking. And
Yeah.
we know that that's not always a good thing. It can be, but not always. So that's how we think that occurs. Is that, and so depending on where the tumor was located, depending on a complication of either surgery or radiation, it is possible that areas of the brain whose connections are necessary just got disrupted. And so what do we do about that? So there are a couple of options. One is that if it's subtle, then psychologists, neuropsychologists who work with brain injuries and people who have this after a concussion, a stroke, or complications of MS, other kind of things like that, can help to both help the patient and families with behavioral strategies that can serve to kind of rein that in a little bit. In some cases, when it's really bad, we do have medication options that we use. They are okay, not great, but they still, in really troublesome situations, we can use them. So the first line is to think about this as a brain injury consequence rather than a behavioral problem, and to potentially seek consultation with brain rehabilitation experts who would treat this like they would, a brain injury that came from another reason.
Okay. All right. Well, Dr. Staab, we are at, we're just about the end of our time today. So I want to thank you. We have tons of comments that say this was a great presentation, very informative, very validating. And so we really appreciate your time answering all of these questions. I want to let people know that we are going to get started again in about 30 minutes. We will have Dr. Weiskopf and Dr. Deep, who are going to talk about balance. And then a little later on today, 2 o'clock Eastern, we will have Dr. Paracelda, who's going to talk to us about the anatomy of acoustic neuroma. So we hope you'll join us. You can find the links through our registration on our website at www.anausa.org, or you can join us on Facebook. So thank you again. Thank you so much for joining us.
Oh, it's been a pleasure. Thanks for inviting me.
Well, we are happy to have you. Thanks so much.
You're very welcome. Bye-bye.